So much
عن
for
السلام عليكم جميعا. احنا طبعا نرحب بدكتور هارون عبيد، بروفيسور الراديولوجي فاكولتي اوف ميديسين رويال يونيفرسيتي هوسبيتال in Canada. طبعا he joining us. I think this is the sixth time for lecture in MSK, and we really appreciate this effort. and حقيقة يعني دكتور هارون دائما سباق برفد طلابنا وطلاب البورد العراقي بالمحاضرات الرائعة. طبعا احنا نوجه له الشكر أنا وزملائي الأستاذ محمد عبد كاظم والأستاذ كاوة والحاضرين من الأساتذة، نوجه له الشكر الجزيل يعني على هذه الجهود القيمة، ونتمنى له كل التوفيق طبعا. فنشكره على هالمحاضرات وعلى الجهود الرائعة. تفضل أستاذ هارون.
Thank you so much, Rad. I really appreciate the introduction, and it's always my pleasure to be with you and contribute as much as I can to your educational program. You have a fantastic group of radiologists, and the activities and the program are phenomenal. So today we will be talking about imaging of the shoulder joint. The objectives of this talk will be, the objectives will be just at the beginning, we cover imaging modalities, all the different imaging modalities, and how they play a role in imaging different shoulder joint pathologies. Then we will cover the most common shoulder joint pathology, and that will include shoulder impingement, rotator cuff pathology, labral pathology, Barcy, and nerve entrapments. So for the radiographs, I'm sure you know this, we normally start imaging the shoulder with radiographs. And radiographs are very valuable imaging test in detecting various shoulder pathologies. And in addition to that, the radiographs can be very helpful for providing some quantitative measurements of the shoulder joint. For example, assessing the critical shoulder angle, assessing the acromial index, assessing the corococlavicular interval, assessing the subacromial joint space. So there are various applications for the radiographs in shoulder pathology, and in addition to detecting, for example, fractures or bony Bankart, soft tissue calcification, and osteoarthritic changes. The next line of imaging for shoulder pathology, and most of these patients present with shoulder pain or shoulder restricted range of motion. The second most useful imaging test from my experience is ultrasound scan. The Philips IU-22 and now the Philips Epic are the best imaging ultrasound machines for imaging the shoulder joint, or in general musculoskeletal imaging. And the frequency ranges from 12 to 17 megahertz. That would be kind of the range of frequency you need for the shoulder joint, for the rotator cuff tendons particularly. The usefulness of ultrasound scan comes from its superior spatial resolution. It's better spatial resolution than MRI, and therefore it is a preferred imaging test for assessing the rotator cuff tendons more so than the MRI scan. It is also useful for detecting inflammatory changes such as bursitis, synovitis, even detecting paralabral cysts and some of the ACJ pathologies. Then we move on to the CT. The CT has a role in the assessment of the shoulder joint, and definitely trauma such as fractures or dislocation are the primary indications. Most of the time when we do CT scan of the shoulder, we normally do it for a fracture and fracture dislocation. But also CT can be used for various other things. For example, quantifying the glenoid articular loss in cases of bony Bankart, for example. It also can be used for quantifying the bone stock preoperatively before doing shoulder arthroplasty. And some of the orthopedic surgeons we have, they ask actually for preoperative CT scan of the shoulder before they do shoulder joint arthroplasty. CT arthrogram is also useful in cases where patients have MRI contraindication, particularly for labral assessment. So that's probably the only time we get to do CT arthrogram on the shoulder joint, is only if they have MRI contraindications and they have labral pathology. MRI is very popular imaging test for assessing various shoulder joint pathologies. There are two techniques that are used for imaging the shoulder pathologies, either conventional MRI or MRI arthrography. These are the two techniques we tend to use most of the time for patients with shoulder disorders. The conventional MRI is the default, the general MRI technique, and that can be used for various pathologies, whether it's rotator cuff pathology, synovitis, bursitis, or cartilage assessment, nerve entrapment. The MRI arthrography is reserved for assessing the labrum and various labral pathologies, Bankart and Bankart variants and slap tears. These are the indications for doing MRI arthrography. With the MRI of the shoulder, the positioning is really important. Most of these patients, we position them with external rotated shoulder. And the reason for that, because we want to mitigate magic angle effect of the supraspinatus tendon. So this is the position, this is the ideal position for imaging patients, particularly for rotator cuff pathology. The shoulder should always be imaged with external rotation because of the magic angle effect of the supraspinatus tendon. The sequences we obtain when we do conventional MRI, these are the sequences here. Most of the sequences are PDFS. So we have sagittal PDFS, coronal PDFS, axial PDFS. We also have a MEDIC, which is a gradient recall echo sequence, and we have sagittal T1, and the sagittal T1 is to quantify muscle atrophy and fatty infiltration. We have started also using CT-like imaging, particularly for patients with shoulder dislocation, to assess Hill-Sachs lesion, to assess bony Bankart lesion. And there are different techniques that you can use to obtain CT-like imaging of the shoulder. The one we use is the T1 Vibe. MRI arthrography, these are the sequences we do on MRI arthrography, predominantly T1 fat saturated. Therefore, you can actually optimize the visualization of the intra-articular gadolinium. We also add to it coronal T2 fat saturated sequence. And the reason for that is because we want to detect paralabral cyst, because otherwise, if all the sequences you do are T1 fat saturated sequences, then you will not be able to detect paralabral cyst. So always make sure you have in the sequences for the MRI arthrography, you have some sort of T2 weighted sequence in the protocol. The labrum appears homogeneously hypointense on all the sequences you obtain, whether T1 PDFS or T2. The labrum should always appear homogeneously hypointense. And also forgot to mention that with MRI arthrography, we do the ABER position, which is abduction external rotation of the shoulder, and that will help us detect Bankart variants. So we'll move on now to the shoulder disorders, and we will start with the most common shoulder disorders that we see all the time. Most of our patients referred for MRI of the shoulder because of the shoulder impingement. There are different types of shoulder impingement. Excuse me. There are different types of shoulder impingement. The subacromial impingement is by far the most common type of disorder that we see. The subacromial impingement is also called the arc syndrome. And the reason for that is because that's where the supraspinatus muscle and tendon are situated. And they are situated in what looks like an arc. It's the boundaries of the arc include the spinous process of the scapula, the acromioclavicular ligament, and the superior margin of the glenoid. So any narrowing of this space or the arc would lead to subacromial impingement. There are various conditions that are implicated in the subacromial impingement, such as different types of acromion. We will look at those different types in a minute. Also, the lateral acromial downsloping. Any osteoarthritis of the ACJ may lead to narrowing of this arc. Also, osteoacromiale and acromial enthesophytes. These are the three different types of the acromion. We use the Bigliani Classification of the acromion: type 1, when the undersurface of the acromion is flat; type 2, when the undersurface of the acromion is concave; and type 3 is when the acromion has an anterior acromial hook. So this is the type 3, and the type 3 is the worst type of acromion because this will definitely lead to the narrowing of the arc for the supraspinatus muscle and therefore create subacromial impingement. Ossa acromiale is another entity that is associated with subacromial impingement. And what we see here is the apophysis of the acromion that failed to fuse with the acromion. Sometimes they can be very symptomatic, especially on MRI. If you saw osseous edema and surrounding soft tissue edema, sometimes they can be symptomatic, and sometimes surgeons will resect the ossa acromiale. So what are the implications for patients if they develop subacromial impingement, whether they have type 3 acromial morphology or they have osteoarthritis of the acromioclavicular joint? These patients will develop various problems. The most common ones is obviously rotator cuff tendinopathy or rotator cuff tears. And secondly, they will develop subacromial bursal thickening. As we can see here, we see there's thickening of the subacromial bursa, and that is commonly seen in patients with subacromial impingement. The rotator cuff tendons, let's start with the rotator cuff tendons. The rotator cuff tendons are very important for the shoulder joint because these are the primary stabilizers of the shoulder joint. And because of that, any rotator cuff pathology, rotator cuff tears, they will have surgical implications. Normally, these patients will undergo surgical repair of the rotator cuff tendons. There are various conditions that can develop in the rotator cuff tendons, such as tendinosis, calcific tendinosis, rotator cuff tears, and then we will also see examples of those different types of tears and the muscle atrophy. So how does for example, the supraspinatus tendon, the normal supraspinatus tendon looks like? Then if we understand how normal supraspinatus tendon, for example, looks like, then we can determine if the tendon is normal or abnormal. The normal supraspinatus tendon will have what we call the fibrillar pattern. These are the fibers, the tendon fibers. They should be nice and linear and organized. So that's how a normal supraspinatus tendon would look like. This part of the insertion, we call it the footprint, and this part we call it the critical zone of the supraspinatus tendon. On MRI scan, very similar type of appearance to the supraspinatus tendon. It's nice and homogeneous with no signal change, with no heterogeneity, with no focal defect. So that's how a normal supraspinatus would look like on MRI scan. So, okay, so I have some cases here just to make it interactive. And if we have any volunteer that would want to look at this case, I would be happy to help you as well as we go along.
دكتور عقيل.
السلام عليكم.
عليكم السلام.
عليكم السلام.
History موجود, 37 years old male.
Here is multimodality. There is X-ray and ultrasound, also CT and MRI of the shoulder joint, showing there is the on ultrasound there is heterogeneity of the supraspinatus muscle with the also calcification seen on shoulder X-ray, and also on the MRI we see area of signal void at the tendinous attachment, tendinous footprint of the supraspinatus muscle, suggestive of calcific tendinitis of the supraspinatus muscle.
Okay, yeah, thank you so much. Yeah, absolutely. You did really well. Normally, I would recommend you start with the X-ray. So I would describe this one as focus of calcification adjacent to the greater tuberosity of the humerus. And then you can move on to the ultrasound scan. You would say there's amorphous calcification involving the infraspinatus tendon. And then you can move on to the CT. There is obviously this focus of calcification in the rotator cuff tendons. There's another one here in the infraspinatus tendon. And there is focal area of bony erosion or bony resorption. And this is another feature that we can see in patients with hydroxyapatite deposition disease or calcific tendinosis. And then on the MRI scan, yes, as you described very well, there's focal area of signal void at the insertion or the footprint of the supraspinatus tendon in keeping with calcific tendinosis. So let's move on now.
Okay.
Tendinosis is a case, or the pathology really is degeneration of the tendon due to the breakdown and disintegration of the collagen fibers due to overuse of the tendon. The term tendinitis is obsolete. We don't use it anymore because it's not inflammatory condition, it's more of a degenerative condition. Therefore, the accurate terminology is tendinosis. So on ultrasound scan, tendinosis will look like heterogeneity of the tendon. We remember how the tendon looked like when we looked at the normal supraspinatus tendon. It did have what we call the fibrillar pattern. Here we don't have fibrillar pattern. The tendon is disorganized. There is sometimes the vascularity that can be detected, but it's really variable, and I don't see it most of the times. Like sometimes very infrequently, I see there is increased vascularity in the supraspinatus tendon. And on MRI scan, tendinosis will again look like heterogeneity of the signal. Remember how the tendon looked like on the MRI scan. It was homogeneously hypointense with no signal change. However, in this patient, we see there is signal change involving the supraspinatus tendon insertion, and we see it both on the coronal PDFS as well as on the coronal T2. So I'm going to just move this one here. So we see that signal change on both PDFS and also on the T2. Because if you saw that signal change on the PDFS alone, not on the T2, this could actually be magic angle effect. Therefore, you should always look at both the PDFS as well as the coronal T2. And the one that we just looked at is exactly what we already described, is the calcific tendinosis, or what we call hydroxyapatite deposition disease. These patients present sometimes with acute shoulder pain during the resorptive stage of the hydroxyapatite deposition disease, and sometimes the pain can be so intense that these patients present to the emergency department with symptoms of septic arthritis of the shoulder joint. The treatment options for these patients is barbitage, aspiration of the calcific tendinosis. Okay, we have another case.
Okay, one have to start with the simplest modality like X-ray, then ultrasound, then go to CT and MR.
Yes, exactly.
Yeah. نختار دكتور مرتضى.
نعم أستاذ، السلام عليكم.
عليكم السلام. هذا الكيس نمبر 2. تفضل.
40-year-old female right shoulder pain, lifting heavy objects, subacromial impingement test positive. On ultrasound scan, I can see a hypoechoic focus along the course of the supraspinatus tendon, and on MRI scan, the coronal image show hyper-intense focus. It appears hyper-intense on T2 and hypo on the other sequence, I think PD fat-SAT. It looks like a gap along the course of supraspinatus. So I think there is a partial tear of the supraspinatus tendon.
Okay, and the partial tear, is it articular-sided or bursal-sided?
It is on the articular side.
Yes, correct. Yeah, so this is articular-sided partial thickness tear of the supraspinatus tendon. When we comment on the rotator cuff tendons in general, we have to comment on the location of the tear. So whether it is, for example, in the footprint, this is the footprint of the tendon, or if it is in the critical zone of the tendon, which is here, the critical zone of the tendon. So these are very important. That's on the coronal plane. On the sagittal plane, you also need to comment on the location of the tendon, whether the tear, whether it is in the anterior fibers, in the mid-tendon, or in the posterior fibers. Orthopedic surgeons, where I work, always ask for the location of the tear. So we cannot just say partial thickness articular sided tear. We have to say whether it is footprint, critical zone, anterior fibers, or posterior fibers. And then after we comment on the location of the tear, we have to comment on the size of the tear. We use the Snyder classification system. So you measure the tear in the long axis. So for example, in this direction here, the long axis of the tendon, and then you quantify it, grade 1, 2, 3, or 4, depending on the size of the, or the length of the tendon as described here. And also we measure the thickness, how much there is loss of the thickness of the tendon. And we use this grading system, either low grade if it is less than 3 millimeter thickness, intermediate grade if it is 3 to 6 millimeter loss of the thickness, and high grade if it is more than 6 millimeter loss of the thickness of the tendon. This is considered high grade, intermediate grade, and low grade. So with the case we looked at was footprint partial articular sided tear. We have another case here where actually the tear is in the critical zone. And this type of tear called the STAS tear, which stands for supraspinatus tendon articular sided tear, but that is not in the footprint. The one in the footprint called PASTA, we will look at in a minute, but this one called STAS. STAS involves the critical zone of the supraspinatus tendon. And one of the interesting features with this one, how to recognize it, is what we call the cartilage interface sign. Normally, if the tendon is intact, you're really barely able to see the cartilage, the hyaline cartilage of the humeral head. However, if there is focal partial thickness articular sided tear in the critical zone, you will be able to see the hyaline cartilage of the humeral head, and this is described as the cartilage interface sign. The another feature that you can detect, so for this case, it was easy because we could see fluid-filled gap in the critical zone of the supraspinatus tendon. So this is easy to detect and easy to diagnose. Sometimes you don't see the fluid-filled gap. So that will make it a little tricky and challenging because there is no fluid-filled gap. But there are indirect signs for partial thickness tear called the sagging of the fibers. And if you follow the dorsal surface of the tendon here, the supraspinatus tendon, you will see there's a dip here, and then it goes back up. So there's a dip here in the critical zone of the tendon. This is called the sagging of the fibers. And sagging of the fibers means there is a thinning of the tendon, and that thinning is because there is partial thickness articular sided tear. However, the tear is not fluid filled. Now you can, if you want to make this tear fluid filled, by doing abduction and adduction of the joint, or internal rotation, external rotation of the joint, in order to force the joint fluid to move from the joint recess here to track and fill the gap in here. So there are a few maneuvers that you can do in order to make this tear fluid filled, but always be mindful of the sagging of the fibers because it's an indirect sign of partial thickness articular sided tear. And the partial thickness articular sided tear, if it happens in the insertion of the tendon, such as the case that you looked at, this one is called PASTA tear, which is partial thickness articular sided tear of the supraspinatus footprint. And the same thing also you can see on the MRI scan. Sometimes it can be called rim rent. So if you heard about PASTA or rim rent, they are the same, both of them. One of them is radiologic and the other one is arthroscopic. And sometimes the arthroscopic surgeons would use a different terminology than our radiology terminology. The other type of tear partial thickness is the bursal-sided tear, and this is called reverse pasta. So remember, pasta was the articular-sided tear at the footprint here, there. However, the reverse pasta is actually partial thickness bursal-sided tear at the footprint of the supraspinatus tendon. Another type of supraspinatus tear is what we call the CID, which stands for concealed interstitial delaminating tear. And the reason why it's called concealed is because if they do arthroscopy, they will not be able to see the tear. If they inspect the articular side, they don't see it. If they inspect the bursal side, they don't see it. And the reason for that is because the tear is actually hiding within the tendon fibers. So this kind of tear, the interstitial, concealed interstitial delaminating tear, will not be visible during arthroscopy. That's why MRI scan is really helpful, or ultrasound is really helpful for these patients, because we can detect them on imaging. Okay, we have another case.
اوكي استاذ هارون، عاشت يدك. نختار دكتوره سماء عطيه.
نعم أستاذ، صباح الخير.
صباح الخير.
This is
45-year-old male, left shoulder pain and weakness with pseudo paralysis.
okay. This is a multimodality images that show there is there's a classification around the humeral head and the X-ray, and irregularity on the humeral head, and show thinning of the rotator cuff muscle on ultrasound. And I think there is high signal intensity on the supraspinatus muscle.
Okay, yeah. Thank you.
I think this is OA, mostly with the OA changes affecting the supraspinatus muscle.
Okay, yeah, thank you. So if we go back to the radiograph, what would you say about the subacromial space here?
There is a decrease of subacromial space.
And what does the narrowing of the subacromial space mean?
A decrease in OA changes, mostly.
Okay, so the narrowing of the subacromial space is actually an indirect sign of full thickness rotator cuff tear. And as we can see here on the ultrasound scan, we have lost the supraspinatus tendon. We don't see any fibers. We see deltoid and we see humeral head, but we don't see supraspinatus tendon. And as well as on MRI scan, we see this fluid-filled gap on the coronal PDFS and also on the coronal T2, and we see muscle atrophy. So the narrowing, or what we call it, the superior migration of the humeral head, are signs of full thickness rotator cuff tears. So in the previous few examples, we looked at the partial thickness tears. We talked about the partial thickness articular, partial thickness bursal. We also talked about the concealed interstitial delaminating tears. Now we move to different group of rotator cuff tears. We call them the full thickness tears. And the full thickness tears can be either focal. So for example, this is the sagittal short axis image of the supraspinatus tendon. We see the mid and posterior fibers of the supraspinatus tendon, but we don't see the anterior fibers of the supraspinatus tendon, and we see fluid-filled gap here. As also the same thing on the long axis image of the supraspinatus tendon. We see tendon gap here and tendon retraction here. So this is called focal, and the reason why it's called focal, because it involves one part of the tendon, which is the anterior part of the tendon. Here we have a different type of full thickness tear. We call it complete full thickness tear. And complete full thickness tear means the entire width of the tendon is gone. We don't see the tendon anymore. This is the long axis image. We don't see the tendon. And also the short axis image, we don't see the tendon. So the tendon is completely disappeared. And this is called complete full thickness tear. And patient with complete full thickness tear, their ultrasound image, what we call it bare bone, because the bone is not covered by the supraspinatus tendon. And these patients present with pseudoparalysis because they cannot do abduction of the shoulder joint. And another sign of complete full thickness tear is what we described already, the narrowing of the subacromial space or the superior migration of the humeral head. Normally, you would allow about 7 millimeter, at least 7 millimeter for the subacromial space, but if the space is less than 7 millimeter, this is called superior migration of the humeral head, which is an indication of complete tear of the supraspinatus tendon. On MRI scan, the MRI can be very useful for detecting supraspinatus the muscle atrophy, especially in these patients with complete full thickness tear of the tendon, because they will have tendon retraction, for example, here. And these are the surgical implications for these patients. When surgeons decide to do supraspinatus tendon repair, they would want to know how much there is retraction. They want to know how much there is atrophy. And also another indirect sign of full thickness tear of the rotator cuff tendons is actually fluid leak from the joint into the subacromial subdeltoid bursa. So this is all bursal fluid, this is all bursal fluid, this is all bursal fluid. And here also on ultrasound scan, we see fluid in the subacromial subdeltoid bursa. And that's an indirect sign of a complete tear involving the supraspinatus tendon. On MRI scan, the surgeons would want to know what the status of the muscle before they consider doing surgical repair. So normally we would quantify the muscle atrophy. And the way we quantify muscle atrophy, we use the technique called the tangent line technique, like this line here from the spinous process to the coracoid process. Normally the supraspinatus tendon, about a third of the muscle should be above the line, but here just about a little bit portion, small portion of the muscle is above the line. This is considered mild to moderate volume loss of the supraspinatus muscle. We also use the Guttile grading system for the muscle fatty infiltration. So the more fatty infiltration of the muscle is, the worse is the prognosis for these patients. And you can quantify Guttile fatty infiltration either on ultrasound or you can do it on MRI. Either way, it's helpful. The more there's fat, like grade 4, for example, is definitely not going to be surgically reparable, and that's because the muscle has already died away and it's not viable anymore. Another entity in the shoulder impingement, so we covered the subacromial impingement, now move to another type of shoulder impingement called the subcoracoid impingement. And the subcoracoid impingement is narrowing of this interval or distance between the coracoid process and the lesser tuberosity of the humeral head. Normally is about 10 millimeter, but if it is less than 6 millimeter, it can be associated with subcoracoid impingement. And the problems with these patients is they develop subscapularis tendon pathology and tendon tears, as we can see in this patient. This is a normal patient with subscapularis tendon. Here we see a patient with completely disappeared subscapularis tendon. This is the long axis view, and this is the short axis view, and we see bare bone. There is no subscapularis tendon. So what are the pitfalls with ultrasound? We said ultrasound scan is wonderful in assessment the rotator cuff tendons because of the spatial resolution. However, there is a pitfall with ultrasound scan, and that's the anisotropy. And the anisotropy is when you see focal hypoechoic area at the footprint of the supraspinatus tendon, which can mimic partial thickness articular sided tear. And the useful thing you can do is that rather than having your ultrasound probe in this position, you can actually tilt your ultrasound probe in this position, and you get better visualization of the footprint of the rotator cuff tendons and avoid overcalling this as partial thickness tear when it is actually just anisotropy. Same thing with MRI scan. We talked already about the magic angle effect. That's another pitfall with MRI scan. And always look for the PDFS as well as the coronal T2. So for example, we look here at the coronal PDFS, we see signal change at the insertion of the supraspinatus tendon on the coronal PDFS. But actually, if you look at the coronal T2, the tendon looks normal with no signal change. So then we can call this one magic angle effect. Now, which test is better than the other in imaging the rotator cuff tendons? We published this article in the ultrasound journal, and we looked at the supraspinatus imaging protocol. And this is what we came up with, that for the supraspinatus tendon, patients under the age of 50 or patient with suspected full thickness tear, the best imaging test for them would be ultrasound scan for this group of patients. MRI scan can be useful to quantify muscle atrophy and fatty infiltration. But for these patients, ultrasound would be the first imaging modality or the best imaging modality. Okay, we're done with the rotator cuff tendons. We move on to the proximal long-headed biceps tendon, which can also be implicated in the subacromial impingement. And the proximal long-headed biceps tendon is very interesting tendon because it plays a major role in the stabilization of the humeral head, particularly in patients with rotator cuff tears. We published this article in the Journal of Shoulder and Elbow Surgery. And what we found actually, that patients with intact proximal long-headed biceps tendon, even if they lost the supraspinatus tendon, they will not have superior humeral head migration. So for example, in this patient, we see that the proximal long-headed biceps tendon is torn completely. We don't see any proximal long-headed biceps tendon in the bicipital groove. They also lost the rotator cuff tendons, and therefore they develop subacromial joint space narrowing or superior migration of the humeral head. Another entity that can develop with the proximal long-headed biceps tendon is dislocation of the proximal long-headed biceps tendon. And as we can see in the image here, this is the bicipital groove. The proximal long-headed biceps tendon is medially dislocated. This is a very complicated, and it's a topic on its own, actually, if we want to talk about the dynamics of the proximal long-headed biceps. I think I will skip this dynamics and the biceps pulley for this talk. Maybe in the future we can have a talk about the biceps pulley, but there are different types of medial dislocation of the proximal long-headed biceps. You can either have dislocation that lies superficial to the subscapularis tendon, and this happens because of the tear of the coracohumeral ligament, but you can also have dislocation that can be deep to the subscapularis tendon. If the dislocation is deep to the subscapularis tendon, it means there is tear of the subscapularis tendon. So just remember this. It's a complicated subject, but just remember this. If the dislocation is superficial to the subscapularis tendon like this one, then the pathology is the pulley mechanism or the coracohumeral ligament. If the dislocation is deep, then it is subscapularis pathology, because for the surgeons, it can be quite helpful to tell them where the dislocation is or where the biceps tendon is in relation to the subscapularis tendon. Another pathology that can develop with the long-headed biceps tendon is what we call tenosynovitis, and that is demonstrated by fluid and the halo sign around the proximal long-headed biceps tendon with increased vascularity. So that's another etiology. A normal variant can develop with the proximal long-headed biceps tendon. We call it the bifid tendon. Is that when you have two tendons in the bicipital groove, and that is just a normal variant, but sometimes they can lead to biomechanical problems, and one of these bifid tendons will sublux and cause snapping and clicking of the shoulder joint. Okay, move on to case number 4.
تمام أستاذ هارون. دكتورة تبين جمال.
نعم أستاذ، صباح الخير.
تفضل.
37 years old.
37-year-old male, shoulder joint pain and clicking, instability and locking.
Yes, we have a multiple sequence of the MRI. I can see on the axial image there is a marked joint fusion. Yes, I can see the discontinuity of the subscapularis tendon on the axial image.
You mean this one here?
Yes.
Okay, so let's leave the rotator cuff tendons. I'm going to tell you that infraspinatus, subscapularis, and supraspinatus tendons are normal. If we go back to the history, the problem with this patient is flicking instability and locking. And also, I would like to add, this is MRI arthrography. This is not joint fusion. This is gadolinium.
That's right. Yeah, this is MRI arthrography. I can see that there is abnormal high signal intensity within the superior labrum, superior glenoid labrum.
Yes. Okay. So where is the signal? Is it what o'clock? Is it 1 o'clock position, 12 o'clock position, 6 o'clock position? How would you say?
It is only inferior aspect of the superior labrum.
You mean this one here?
No, no, the one in
the... This is 12 o'clock. This is 6 o'clock.
Yeah, maybe this one, I don't know actually.
You're talking about superior or inferior? This is superior, this is inferior. Which one is it? Superior and inferior.
I can see that there is an arthrogram in the axillary pouch as well. So if we talk about the coronal image, I can see that there is a fluid signal in inferior glenoid labrum. Yes, the glenoid labrum, I see it in the 6 o'clock, maybe.
This one?
Yes.
Okay, so this is coronal T2 fat saturated, and this is coronal T1 fat saturated. Is this signal here, do you see it on the coronal T1 or you don't see it on the coronal T1?
No, actually not. Actually
okay,
not.
So let's leave this one because this is actually not gadolinium, okay? Because here we would have seen it.
Yes, I was...
go on.
Yeah, I was concerned about the superior labrum as well on the coronal image.
Yes, correct. Yeah, this is exactly what the pathology is. So what do you think this is? Here.
This is slap tear.
Slap tear. Okay, so what is a slap tear?
This is superior labral anteroposterior tear.
Okay.
And yes.
Okay. Okay, no, yeah, that's fantastic. So this is, and again, you just, if we just go back to the history, the patient presented with mechanical problems. Normally, patient with rotator cuff tears, they would present with weakness, pain, pseudoparalysis. But patient with slap tear, they present with clicking, instability, and locking. This is a classic clinical presentation for slap tear. And also, if we go back to the MRI scan, we will see this fluid-filled gap here in the labrum. Always, when you look at the T2, you should match it with the T1 FS, because what we're looking for definition of a labral tear is when the gadolinium is actually filling the tear. So the gadolinium is filling the tear here, fluid is filling the tear here. So that is actually a genuine pathology in the superior labrum. Okay, so now we're going to move on to the labral pathology. And when we talk about labral pathology, we always have to locate the tear. So I asked you, for example, what clock face it is. Is it 12 o'clock? Is it 6 o'clock? Is it 5 o'clock? Normally for the orthopedic surgeons, when we put in our report the pathology about the labrum, we always put the location of the pathology in the labrum. And you can use either the quadrant system or the clock face system. It doesn't matter as long as you use one of these systems to locate the tear for the surgeons in the report. You could either say it is superior, or you could say anterosuperior or posterior-superior or posterior-inferior, whatever corner of the labrum or the glenoid it is, or you can use the clock face. When you use the clock face, 12 o'clock is always superior, like this one here. 12 o'clock is always superior, 6 o'clock is always inferior, 3 o'clock is always anterior, and 9 o'clock is always posterior. So remember this, whether the shoulder is left or right, the same clock phase. For a left shoulder, still you will call this 3 o'clock. For a right shoulder, you still call this 3 o'clock. And same thing, this one, this is 9 o'clock for left or for right shoulder. And 12 o'clock is here and 6 o'clock is here. So always use that system. This is how we do it. And most of the places that I worked in and trained in, we use that system. After we give the location of the labral tear, we would always look for paralabral cyst. And the reason why this is important is because during arthroscopy, the surgeons may not be able to see paralabral cyst. So we should always be mindful that we should include it. Slap tears, there are 9 different types of slap tears, but to be honest with you, only 4 different types of slap tears are important, and you should remember and you should know. The one, for example, here was type 1 slap tear. There was fraying and tearing of the superior labrum. This is what we call type 1 slap tear. Another type of slap tear is what we call type 2. And type 2, again, this is contrast gadolinium. This is coronal T1 fat saturated. And we see the gadolinium here tearing the labrum as well as detaching the biceps anchor. So that would be type 2. Definition of type 2 is detachment of the labrum as well as the anchor. And this one is type 3 because it's a bucket handle tear here, but the bucket handle tear does not involve the biceps anchor. And this is considered as bucket handle type 3 slap tear. Here we have type 4 slap tear because the tear is actually extending now into the biceps anchor. So there's maceration and tearing of the labrum as well as the biceps anchor. There's signal change in the biceps anchor. There's signal change in the biceps anchor, and the gadolinium is filling the tear. This is type 4 slap tear. Okay, move on to case number 5.
Okay, رؤى باسم.
نعم أستاذ. First, we have a 28 years old male patient, recent anterior shoulder dislocation after rock tracker, anterior shoulder instability. And on X-ray, there is obviously anterior shoulder dislocation with evidence of bony defect in labrum, superior labrum. On MR arthrogram, also there is a bony lesion, bony defect. I think it is bony Bankart.
Yes, yeah, you are correct. Yeah, this is bony Bankart. Rugby tackle is one of those worst kind of shoulder injuries where patients dislocate all the time. And we can see the fracture fragment here involving the anterior aspect of the glenoid. This is actually after they reduced the shoulder. This was the pre-shoulder reduction, and this is post-shoulder reduction. And as you said, on the MRI, the axial T1 fat saturated sequence, we see this bony fragment here of the labrum. So this is bony Bankart. Now we're going to move on. So we finished with the slap tears. We're going to move on to Bankart and Bankart variants. And most commonly, these develop because of anterior shoulder dislocation, like this patient here. And when they present, they normally present with shoulder instability and multiple dislocations or recurrent dislocations. And because of the instability and recurrent dislocations, they are considered surgical candidates because they are young patients and their joints are very unstable. Therefore, they undergo labral surgery. So what is Bankart? Definition of Bankart is labral tear with periosteal sleeve avulsion. So this is how it looks like, labral tear with periosteal sleeve avulsion. So that's the definition of a Bankart lesion. And again, as always, when we comment on a labral tear, we should always mention where the tear is. So for example, you could say this is anterior or anteroinferior tear, or you can call this tear extends from 3 o'clock position to 5 o'clock position if you want. So anyway, but you have to kind of give it a location where the tear is. And bony Bankart is the same as Bankart, but there is a bony fragment with the labral tear. So this is, again, highly unstable. This is worse than just a Bankart because the articular surface of the glenoid now is deficient. And because the articular surface is deficient, these patients present with instability and multiple dislocations. And the repair, the surgical repair for the bony Bankart is different than the Bankart because for Bankart, they just repair the labrum arthroscopically, but for bony Bankart, because there is a bone loss in the glenoid, they normally take a piece from the coracoid process and graft it here and put 2 screws to incorporate the coracoid graft into the glenoid. So this is kind of how it looks like for these patients after they undergo augmentation surgery for bony Bankart. And these patients with bony Bankart and shoulder dislocation, I mentioned this earlier, we use the T1 Vibe sequence because it provides us with this CT-like capability. So this is how the T1 Vibe looks like, but you can do inversion of the image, and then when you do inversion of the image, it would look like CT, but this is actually MRI. There are other techniques that you can use, the ZTE, the zero-time echo, or ultra-short TE. Also, they provide you with CT-like imaging, but the T1 Vibe is by far the most popular CT-like technique for shoulder dislocation. And because these patients with bony Bankart, they lose the glenoid, they will have bony loss. So they will have Hill-Sachs lesion, and they will have bony Bankart. So sometimes, and I don't know if your orthopedic surgeons ask for this or not, but our orthopedic surgeons would want to know if this bony Bankart and the Hill-Sachs are engaging or non-engaging. And sometimes they call it off track or on track. There is a calculation for doing this, the assessment of the glenoid. Really what it is just to assess how much bony loss of the glenoid there is. So we do this calculation, we measure D, so we place the circle here on the glenoid, inferior portion of the glenoid, and then we measure, the line here would measure the distance from the posterior aspect to the anterior aspect. And then if we have a bone loss here, we would also measure it. And then we apply this equation here that will give us the glenoid track. We assess the Hill-Sachs interval. And then if the Hill-Sachs interval is less than the glenoid, it's called on track. If the Hill-Sachs interval is more than the glenoid track, we call it off track. So this, I don't know if your orthopedic surgeons ask for this, but if you get asked about it, this is how we do it, and this is how we do the calculation. So what is Hill-Sachs lesion? Hill-Sachs is by definition is a fracture. So when they dislocate this part of the humeral head would sit and adjacent to the glenoid here. So this is an impaction injury or concavity of the posterior superior humeral head. Okay, move on now to the next case.
العفو دكتورة إيمان حميد.
نعم أستاذ.
صباح الخير.
Okay. 44 years old, shoulder dislocation, shoulder anterior instability. MRI image axial section showing marked joint fusion with the anterior anterior labral tear and migration of periosteal sleeve.
Sorry, what did you say about the periosteal sleeve?
Migration, يعني صار separation.
Okay. So normally this is what we would say is this is MRI arthrography. This is not joint fusion. And the way to tell whether this is joint fusion or MRI arthrography is firstly the history is instability. And remember, for instability, we always do MRI arthrography to assess the labrum. Secondly, you can see there is injection site here because in our center we do the arthrogram from posterior approach. So when you see injection in the shoulder joint, it always indicates this is an MRI arthrography technique. So there is a labral tear here for sure. The periosteal sleeve is there. This is actually Perthes variant of Bankart. And the definition is for the Perthes is anterior inferior labral ligamentous avulsion with intact periosteal sleeve. So the periosteal sleeve is actually intact, is not torn. Remember for the Bankart, we said periosteal sleeve avulsion. And the case that we looked at, it did have periosteal sleeve avulsion. For here, for example, see the periosteal sleeve is avulsed from the scapula. So that's the definition of Bankart, and that's how we differentiate Bankart from Perthes. Perthes, the periosteal sleeve remains attached to the scapula. So that's Perthes lesion. For the ellipsa is actually medialization of the labral fragment here. So that's an ellipsa, as you can see here. That's ellipsa lesion with medialization of the labral fragment. Another type of labral tears is that when you get a labral tear with involvement of the hyaline cartilage, as we can see here, there's a small fragment of the hyaline cartilage attached to the labrum. Same thing here, there's a small fragment, and here there's a fragment of the hyaline cartilage detached with the labrum. This is called the GLAD lesion, which stands for gleno-labral articular disruption. Now, GLAD lesion is treated differently than labral tears, and the reason for that is because it is not associated with instability. Now, you may get asked this question in the written exam about the GLAD lesion. So all those Bankart and Bankart variants are associated with shoulder instability. However, GLAD lesion is not associated with shoulder instability. And even the mechanism of injury is different. This is a traumatic forced abduction injury. Forced adduction injury. However, with the Bankart and Bankart variants are always shoulder dislocation, but shoulder dislocation is not the problem or not the etiology of the GLAD lesion. Okay, we have another case. Dr. Rad, I don't know how much time do we have? I think we have an hour now. I have about 13 cases. If you want, we can continue, or maybe we continue another day.
ناخذ بعد فد ثلث ساعة نص ساعة
Okay, well, if you want, I can take the cases myself to go fast, or we can still continue inviting the board students.
يلا احنا هسه بس هذه شو اسمه دكتورة هديل، هذا الكيس والباقي حضرتك انت تقدمها.
اوكي.
دكتورة هديل كريم.
صباح الخير يا عمو.
صباح الخير، تفضل.
Okay, 41 years old male, baseball pitcher, left shoulder restricted internal rotation. Okay, we have three different modality, X-ray shoulder, and ultrasound, and MRI retrogram. بالنسبة X-ray, I see there is minimal dislocation of humeral glenoid joint. I think there is dislocations. بالنسبة للالتراساوند كنت أشوف أكو soft tissue heterogeneity and edema and أكو bony fragments. بالMRI توضحت إنه أكو فد lateral أكو lateral tear posteriorly تقريبا، فأتوقع reverse Bankart اللي هو يجي عادة ويا posterior shoulder dislocation.
Yeah. Okay.
Also search for there is reversal sac lesions. I can see perfectly in this image.
Okay, so there is no history of shoulder dislocation. Otherwise, I would have given you a history of shoulder dislocation. The history I gave you is a baseball pitcher and also restricted internal rotation. This is a classic case of what we call Bennett's lesion. And Bennett's lesion is a repetitive overhead. So this is the baseball pitcher. They throw the ball with quite severe external rotation and abduction of the shoulder joint to swing the ball. So they normally present what we call the Bennett lesion. And Bennett lesion is this calcification here that happens at the labrocapsular junction. And you can see that calcification as well on the ultrasound scan. And this is the spinoglenoid notch, and which is here, the spinoglenoid notch. You can see this calcification in the posterior labrum. You can see this calcification or low signal change in the labrum with the labral tear. As you said, this is a MRI arthrography. So this is a baseball Bennett lesion. And the restricted internal rotation history that I gave you here is what is called the GERD, which stands for glenohumeral internal rotation deficit, which is a classic clinical presentation for these patients. Next case is actually an interesting case. I will take the case just to get faster here. So ultrasound scan of the spinoglenoid notch, we see cystic lesion in the spinoglenoid region. Measurements are provided here. And on MRI, we see there is large cystic lesion in the spinoglenoid notch at the posterior aspect. We can also see there is labral defect, and the cyst appears to arise from the posterior aspect of the labrum. We can also see that there is edema of the infraspinatus muscle. If you compare infraspinatus muscle to teres minor muscle, for example, we see there is infraspinatus edema. So this is a case of entrapment neuropathy, and there are different types of entrapment neuropathy. This is the entrapment neuropathy in the spinoglenoid notch because of the entrapment of the suprascapular nerve in the spinoglenoid notch. Remember, if you get entrapment of the suprascapular nerve in the spinoglenoid notch, you get denervation myositis of the infraspinatus muscle. However, if you get entrapment of the suprascapular nerve in the suprascapular fossa or notch, you get denervation myositis of both supraspinatus and infraspinatus muscles. But for this one, it's only infraspinatus muscle because it's in the spinoglenoid notch. Another case of entrapment neuropathy here around the shoulder is what we call the quadrilateral space, which is the space between teres major, teres minor, long head of triceps, and the humerus here. This space here, we call it the quadrilateral space. And the reason why this is important is because there is neurovascular structures that actually go through the quadrilateral space. This is the axillary nerve. So in this patient, we see there is posterior-inferior labral tear with a paralabral cyst, and the cyst is growing and extending into the quadrilateral space. We see denervation myositis of the deltoid muscle. We see denervation myositis of the teres minor muscle. So remember, the deltoid and teres minor muscles are provided by the axillary nerve. So this is a case of entrapment neuropathy of the axillary nerve in the quadrilateral space. So this is a quadrilateral space syndrome. Another case is a 50-year-old male patient presented with acute onset right shoulder pain and weakness with no history of trauma. And on MRI scan, we see all these MRI sequences. We have PDFS in 3 planes. We have the coronal T2, we have the sagittal T1, and the medic sequence. We see there is edema of the infraspinatus muscle. And remember, when we saw that case of spinoglenoid notch, if there was a lesion like this one, which is compressing the suprascapular nerve, it will lead to denervation myositis. But in this case, we don't have any lesion in the spinoglenoid notch. This is the spinoglenoid notch, and this is the suprascapular nerve. There is no entrapment. There is nothing in the spinoglenoid notch. So why does this patient have shoulder pain, weakness, and also the MRI scan is showing denervation myositis of the infraspinatus muscle? This is a case of Parsonage-Turner syndrome. And Parsonage-Turner syndrome is a brachial plexus neuritis. The brachial plexus neuritis could involve any nerve in the brachial plexus, most commonly the suprascapular nerve. And in this patient, did develop neuritis of the suprascapular nerve. The good thing is that it is self-limiting condition. This will resolve on its own. with no significant disability or morbidity to the patient. Another case, we have 44-year-old female patient presented with acute shoulder pain. Patient is paraxial with systemic features, limited range of motion. We start with the radiographs, and as we look at the radiographs, there's soft tissue swelling, and we see foci of air in here in the soft tissue, also foci of air projecting over the humeral head. And we move on to the CT scan. We see fluid collection in the subacromial subdeltoid bursa with multiple foci of air within the bursa. And same thing here on the coronal, we see fusion in the bursa with the foci of air. So this is a case of septic bursitis of the subacromial subdeltoid bursa. These patients can develop bursitis, especially if they had intramuscular injection into the deltoid muscle. Sometimes they develop, the patient will receive intramuscular injection for whatever reason, whether vaccination or any type of antibiotics. But when they deliver the antibiotics, sometimes if the needle is contaminated, it may reach the subacromial subdeltoid bursa, and this patient may develop septic bursitis in this region. We have another bursa around the shoulder. We call it the subcoracoid bursa. Remember, the subcoracoid bursa communicate with the shoulder joint. So if there's a fusion in the shoulder joint, they would develop the fluid also in the bursa. There's another bursa in the shoulder we described in our article in skeletal radiology. This is called coracoclavicular bursa. This coracoclavicular bursa sits between the coracoid process and the clavicle. And in our paper, our results shown that this bursa becomes inflamed if there's narrowing of the coracoclavicular interval less than 5 millimeters. The prevalence is about 9% on shoulder MRI, and these patients present with anterior shoulder pain. So remember, if you saw fluid in this area, this is actually coracoclavicular bursa. Another bursa around the shoulder is the scapulothoracic bursa, which is actually this fluid here between the scapula and the chest wall. The fluid is the edema here. You can see the fluid here. So this is scapulothoracic bursa, and these patients present with scraping scapula. So they have unique clinical presentation. So remember this, if you saw fluid in this region between the scapula and the chest wall, this is scapulothoracic bursitis. Another case, we have 38-year-old female patient, history of rheumatoid arthritis, right shoulder pain and swelling, no fever. And on the radiographs, we see focal area of cortical erosion in the humeral head. Joint space is normal. So this is not septic bursitis, because with septic bursitis, the first thing that we see is actually narrowing of the joint space. But the joint space is actually preserved, but they have an erosion here. And on MRI scan, we see rice bodies in the subacromial subdeltoid bursa. You see these rice bodies here. So this is a case of rheumatoid bursitis. Not a septic bursitis, but it's actually inflammatory bursitis. So that's erosive arthropathy. Another patient, we have 32-year-old male weightlifter with right superior shoulder pain. On the radiograph, we see there's bony resorption of the lateral end of the right clavicle. We see widening of the acromioclavicular joint. On MRI scan, we see widening of the joint, bony resorption of the clavicle, edema in the bones. So this is bony resorption or osteolysis that happens because of repetitive stress injury, because remember the history was weightlifter. So those weightlifters, they present with osteolysis of the clavicle and the synovitis of the joint because of repetitive overuse of the ACJ. Case 13, we have 23-year-old female patient presented with direct fall on the left shoulder joint, presented with anterior shoulder pain. These are both shoulders, right shoulder, left shoulder for the same patient. When we look at the acromioclavicular joints, we see normal acromioclavicular joint here. We see normal coracoclavicular distance here. However, on the left side, we see the subluxation, the superior subluxation of the left acromioclavicular joint, we see widening of the coracoclavicular interval when you compare it with the right side. So this is a case of type 3 ACJ injury. So the most common mechanism of ACJ injury is fall or a direct blow to the shoulder, especially when the arm is adducted like this position. That's how these patients or players present with ACJ injury. We use the Rockwood ACJ classification system for different types. For type 1, normally they have normal ACJ, they have normal clavicular distance. They only present with shoulder pain, but you might need to consider doing radiographs with and without weights. And that's because sometimes it can be difficult to differentiate between type 1 and type 2. So sometimes we ask this patient to carry weights, and we do radiographs before weights and after weights to see if there is widening of the ACJ. If there is no widening of the ACJ, we call it type 1. If there is widening of the ACJ, we call it type 2. And this is type 2 ACJ injury. We see widening of the acromia of the ACJ, which is normally up to 7 millimeter. If it is more than 7 millimeter, we call it type 2 ACJ injury. And this is type 3, the one we looked at. And there is superior subluxation of the ACJ with widening of the coracoclavicular interval. So this is type 3 acromioclavicular joint injury. This is an interesting case I saw last week. Patient presented with shoulder pain after fall, no x-rays. So we did the ultrasound scan and we saw this cortical break in the proximal humerus. Then we requested x-rays and we saw the fracture. So remember, sometimes on ultrasound scan, you can actually see fractures. So be mindful of that. Okay. So in summary, we tried to emphasize the terminology. Knowing the terminology and the definition of the pathology is really crucial in the accurate diagnosis and assessment of the shoulder joint. So what we talked about, for example, tendinosis, the term tendinitis is no longer used. We talked about different definitions of the Bankart and the Bankart variants, because each one of them would have different imaging appearances. We talked about the imaging modalities and how they play a role in the shoulder joint assessment. Ultrasound scan is your kind of first line of imaging for rotator cuff pathology, especially in young patients and with patients with full thickness tears. MRI can be used in patients with full thickness tears to assess muscle atrophy and fatty infiltration for surgical assessment. There's also the role of imaging in the preoperative quantitative assessment of patient with shoulder dislocation, as we talked about those cases with bony Bankart and Hill-Sachs lesion, whether they are engaging or non-engaging, or if the glenoid is on track or off track. We can do preoperative assessment, quantitative assessment of the glenoid bony loss, and help the orthopedic surgeons determine if the patient would need augmentation surgery, for example. And lastly, we talked about different types of entrapment neuropathy around the shoulder, such as the spinal glenoid notch, the quadrilateral space, and also talked about other entities such as neuritis, Parsonage-Turner syndrome. But these cases can be quite challenging, can be confusing. So just be aware and familiar with these cases and you will be fine. Thank you so much for your attention. If you have any questions, you can ask me now or you can drop me an email. Either way, I'm fine to answer your questions.